All right, well, good afternoon, everyone. Welcome to our series, It's Worth a Shot. Today is May 4th, 2022, and this is the 16th edition in our series. Today, we're going to discuss vaccine access, specifically updates for Montana, and review some cohorting best practices. We are very fortunate to have two guest speakers with us today, Erica Baldry and Tricia Gardner. Next slide, please. So before we start today's presentations, I just have a few housekeeping items. Of course, you know, we have decided to carry this through the end of the year. So if you have any webinar topics or ideas or needs, feel free to enter those in the chat and we can explore those further. And also, I do have one item I wanted to follow up on. In March, there was a question out of Alaska, and the question specifically was, wanted to know that with the new pneumo vaccines, they wanted to know what the state was going to do as far as offering the pneumo 15 or the 20 and what the decision was for the formulary. I have to share forward, hot off the press, as of last night, the state of Alaska has decided to add the PCV 20, the Prevnar 20, to the formulary. And they did share forward that an EPI announcement will be published soon. So stay tuned for that, but I did want to follow up in regards to that question. The committee had made that decision. Again, for Alaska, they decided to go with that PCV, the Prevnar 20, for their pneumococcal vaccine formulary. All right, next slide, please. So with that, I would like to introduce our first guest that is going to present on COVID-19 vaccines in Montana. We have joining us Tricia Gardner. She's the Adult Immunization Coordinator for Montana. Oh, I think we have someone off a mute. Everyone will check their mute, please, or their mute button. Again, I'd like to introduce Tricia Gardner, the Adult Immunization Coordinator for Montana. She entered the field of public health in 2009 and really has been privileged to work in several different areas of public health. She started in the area of HIV, STD, and Hep C care and prevention in 2009. And she moved into the accreditation and privacy sector in 2014 and finally became the health officer for Cascade County in December of 19 until about 2021, December 2021, at which time she moved to her present role as the Adult Immunization Coordinator. Happy to share, Tricia is a Montana native, has 2 teenage children, and enjoys travel, reading, music, art, and family. And again, we are very excited to have her presenting for us today. So with that, Trish, I will give you the floor.
Thank you, Jessie. Next slide, please. So I'm just going to do a quick overview of what some vaccine availability is here in Montana and how you might be able to enroll that or enroll in the program or resources available to help you get residents or those that you're working with vaccinated. So we do have over 350 enrolled providers in the state of Montana. That does cover every county. We're currently working with a number of different professional organizations to increase interest in becoming an enrolled provider or find ways that we can increase access. That includes this group, of course, as well as like the Montana Primary Care Association, Montana Public Health Institute, and a couple others. We still use at this time MTRAX, which is our immunization enrollment system. is how people are able to order the vaccine. So we're not doing the ordering for them. People are able to order those minimum ordering as they wish once they become an enrolled provider. And it really has, we've had the ability to expand who can give those vaccines, as most of you probably already know, because of the PrEP Act. That does include, that is covered through October of 2024, regardless of local emergency declarations. So just as an FYI, if that's something you're working under, the liability associated with that does go on for quite a bit longer. Next slide, please. So I know one of the things I've heard a lot from places is concerns about storage and handling with regard to the vaccine and not wanting to become enrolled because storage and handling has been different and maybe a little bit more difficult than routine vaccinations. I can say stability has gotten a lot better for both of these vaccines, and they are getting easier to use. Moderna now is able to be refrigerated for up to 1 month. You don't have to use any diluent with it. Once you puncture a vial, you have 12 hours to use that before you have to dispose of it. So it's fairly standard storage and handling in regards to that. Pfizer also is getting better. Both the gray and the orange cap. There has been purple cap, which was adult as well. The gray is an adult vaccine. Those can be stored now in the refrigerator for up to 10 weeks. And there's no diluent involved and no mixing for the gray cap now. Purple is kind of slowly making its way out and will be replaced by that gray. Unfortunately, the children, the orange cap, and potentially ones coming down the road do still require mixing. But they've also extended the shelf life for ultra cold storage on both of those. And we can certainly here at the state help connect you with somebody with an ultra cold storage unit if that is something you're interested in doing now that you do have those 10 weeks for refrigeration for that. Biggest thing to remember if that's a situation that you're working with is that while transportation is happening, temperature monitoring still needs to be ongoing throughout that transportation. Next slide, please. So as I mentioned at the beginning, one of the things that happened because of COVID was eligibility has expanded. So with the PrEP Act, they did expand that to include currently licensed or certified health professionals, active or recently retired health professionals, and healthcare students. So really that means just about any health facilities, including all long-term care facilities that are willing to store and administer the vaccine are eligible to become part of the program. And you can easily enroll with the state of Montana if you're here just by visiting our webpage. We have an online enrollment process, and that's immunization.mt.gov. Next slide. So wanted also to touch on some things that are coming down the pike with regards to future COVID vaccines. There have been a number of meetings scheduled for the next month to discuss a couple of different things. One is on June 7th, FDA is convening to discuss the vaccine being manufactured by Novavax, as well as June 8th, 21st, and 22nd. They have meetings going on to discuss Moderna and Pfizer packets for pediatric vaccines that are coming down. And in fact, Moderna just released today that they have gotten their packet in. So there's even potential that date could move up. As well, on June 28th, they're going to be discussing strain composition, how it should be modified, and if so, which strain should be included for fall 22 for ongoing boosters. That's a follow-up meeting to an April 6th discussion that happened. So at this point, it really is looking like this will be an ongoing booster situation, and that's something they're exploring at those meetings. Right now, as far as commercialization, I know there's been a lot of talk about maybe things hitting the commercial market. There is no set date at this point. So as of right now, all of these vaccines are still going to be under government contract and provided through public funds. However, sometime down the road, and I'm talking fall or later, I wouldn't expect anything even remotely sooner than that. They're looking at revising that so it's similar to other vaccines, where there will be some publicly funded vaccine for COVID and some vaccine available for private purchase through the commercial market. And next slide. And finally, just wanted to say, I know that a lot of the big mobile clinics that were ongoing really strong at the beginning aren't available anymore. However, there are some resources that we have at the state. We work with some private pharmacies that are willing to travel to locations and more than happy to help administer vaccines. We also have great connections with the health departments and federally qualified health centers throughout the state that oftentimes can come help with, administering as well. So please, 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 if you need any help coordinating that, reach out to myself here at the state. My information is there on the slide, and I'm more than happy to try to coordinate something with any of your facilities to make that a possibility. And that's all I've got. Any questions for me?
Thanks, Trish. And I actually have a question for you.
Yes.
And maybe you just answered it, actually. We're hearing and seeing a decrease in those health department hours, in our state as well as our neighbors. And they have really been a partner for throughout the state and the region for administering the COVID vaccines and boosters. In our long-term care centers. What recommendations do you have for those folks that were maybe relying on the health department primarily for assistance?
I think, with those situations, a lot of the health departments have pulled back. They haven't had quite the same demand that was there previously, but they do still have the ability and are willing to help with off-site clinics, or even extending, working different hours, things like that, to help facilities get all of those completed. And that is a place where we as the state are happy to help step in and help coordinate those. If you're finding a local health department just has said, nope, we're not doing any more, we can certainly advocate on your behalf to help get that resource back in your facility.
Okay, thank you. Thank you. That's a very helpful. I appreciate that. Do we have any other questions? And if you guys think of anything, we can do Q&A towards the end of the presentation as well. All right, perfect. Thank you, Trish. Really appreciate it.
Thank you.
Next slide, Mary. So with that, I'm pleased to introduce another Montana native and our second guest speaker for the day, Erica Baldry. Erica serves as the Infection Control and Prevention and Healthcare Associated Infection Section Supervisor, say that 10 times fast, for the Epi and Scientific Support Bureau at the Montana Department of Public Health and Human Services. Her work focuses on antibiotic stewardship, multi-drug resistant organisms, outbreak response, and infection prevention. Erica started her career with the state in August of 2017. She received a Bachelor's of Arts degree in ecology and organismal biology and a master's in public health from the University of Montana. Erica, as mentioned, she's another Montana native, born and raised in the eastern part of the state, and enjoys being able to serve Montanans. She is here today to discuss best practices of cohorting. Thank you, Erica.
Thanks, Jessie. All right, next slide, please. All right, so we're going to start off with a polling question. So we'll see if we can get that pulled up. But has your facility incorporated cohorting into your infection prevention practices? So yes, no, or unsure. And then Jessie, if you just want to let me know when that poll looks like it's completed.
There we go. Are you able to see that at all, Erica, the polling results?
I can't, so if you want to share that.
Yes, yeah. So it looks like about 63% of you replied yes, you have incorporated cohorting into your infection prevention practices. 21% said no, and about 17% said unsure.
All right, well, perfect. Hopefully this will help you figure out kind of what cohorting it is and when to use it. Next slide, please. What is cohorting? Cohorting is the assignment of a geographic area to 2 or more patients who are infected with the same pathogen and do not have evidence of co-infection with another pathogen. So cohorting is very pathogen specific. We don't just say anyone with any infectious disease will be cohorted together. And this is oftentimes when we're first investigating an outbreak of a communicable disease and we might not know exactly what it is. We need to get testing done and confirm the diagnosis so then we can cohort properly. Cohorting refers to designating a unit or an area. So it might be an area at the end of the hall. It might be an entire unit or wing, or it might even be just a single room within a facility, or placing 2 or more patients with the same pathogen in the same room. And then principle-based cohorting contributes to the control of outbreaks. So the reason that we cohort is we want to control the spread of an infectious disease. Next slide. So if you guys don't mind using the chat feature, I'd be very interested in you guys answering this question. So can you think of why we would cohort patients or residents with the same pathogen? Why is cohorting important? And if you guys just want to use chat, and put in a couple of ideas here, and then I'll share the list that I made with y'all. Perfect, Jessica. Yep, help stop the spread. Can you think of any other reasons why we might want to cohort? So I'll just share my list with you guys. We want to control the spread of disease, just like Jessica said. We want to limit exposure to other residents. Yep, better use of PPE, more efficient for staff. Good job, guys. Yeah, so spot on to kind of the list that I was making. Limit exposures to others, and that would include staff and residents. Limit the outbreak period. A lot of times when we put facilities into outbreak mode here in Montana, I'm getting asked, all right, when can I end my outbreak, right? So the quicker we can control it, the quicker we can close your outbreak. We also might use it because of PPE, and I saw somebody put that in there too, right? I know COVID, we experienced a lot of PPE shortages, and so this allows us to really be more cognizant of how we're using our PPE, and it also helps reduce environmental contamination. Next slide, please. All right, so ideally, and I think we all know we don't always live in an ideal world, so that's why I like to use that language, but ideally areas should have physical separation. So you have a COVID unit separated from the rest of your facility. If barriers are added to create physical separation, you should consider the heating, ventilation, and air conditioning, or HVAC, and there should be air exchange in and out in all partitioned hallways. And there is a fire safety concern. So adding physical barriers may block safety egress routes, and this will likely need approval from your facility safety officer. So you'll definitely want to chat with those individuals when you're thinking about creating and setting up your COVID unit. Next slide, please. Now, if we can't use an entire unit or an entire area, if separation is by individual or cluster of rooms, we could consider using visual cues such as signage or a line of tape on the floor. And I know I've seen that in a couple of our facilities where you'll have tape and say, okay, now you are entering, the infectious area or something like that. I really like visual cues because it kind of stops your staff or stops individuals and says, hey, stop, what do I need to do for this specific unit? Resident room doors may need to be kept closed, but once again, check with life safety. We want to make sure if we're taking these additional steps or we're implementing these additional steps that we're doing so properly and that we're doing so within CMS limits. Next slide, please. Now, I think you guys have all experienced this, but what happens when our COVID unit becomes full or we can't expand our COVID unit any further, or we're limited on our single rooms? We have some facilities that are all double occupancy. What are we supposed to do then? We can't set up an entire COVID unit or things like that. So if we're limited on our single rooms, or if numerous residents are simultaneously identified to have exposures or symptoms, residents should shelter in place. So this is, in Montana, where we would ask facilities to work very closely with public health to make the decisions of when do we stop utilizing a COVID unit and just kind of, use the whole facility as a COVID unit, right? Where we might have to wear full PPE and we have to change that in and out. Where, we have to really be effective at our cleaning, our environmental cleaning. We need to train all of our staff on how to don and doff PPE properly. And so these are conversations that develop over time. And, in Montana, why we are checking in with our facilities, if not daily, at least weekly, to say, hey, how are things going? How's your COVID unit setting looking like? Do we need to have a one-on-one consult call to discuss expanding your COVID unit, or maybe, expanding to the entire facility? And so there are scenarios where maybe a COVID unit doesn't make sense anymore, and moving residents is doing more harm than it is for good. So this is, something we need to discuss with public health as well as the facility. Next slide, please. In an ideal world, once again, we would have dedicated unit for the infectious disease. So we might use cohorting for other infectious disease types, such as MRSA or C. diff, or during a norovirus outbreak or during an influenza outbreak. But I think a lot of us have learned about cohorting through COVID-19. We'd also want dedicated staff for the infectious unit, right? So we'd have dedicated CNAs and nurses and housekeeping, and those are the only individuals, they only work that unit. They don't go on to the non-affected unit. Once again, an ideal world, right? I think many of you have gone through COVID-19 outbreaks where we had limited staff and we had to share staff between units. And that's another discussion to be had, right? You'd want a dedicated bathroom or break room for staff on the affected unit. So if you had a COVID-19 unit set up, you'd want a dedicated break room, bathroom on that unit, as well as a dedicated entrance for that staff. So once again, we're limiting any additional exposures that might be occurring in your facility. We're not having our staff mix amongst one another. We're not having staff that have potentially been exposed, caring for those that are negative. We're trying to limit our circle of exposures and keeping that as small as possible. All staff should use appropriate personnel protective equipment. And I think once again, we learned maybe our PPE isn't always available. Maybe the N95 respirators that our staff are fit tested for aren't available. We can't get it. So I think, we've all learned how to pivot, and we've all learned how to be creative with coming up with solutions. So once again, ideal world, this is what we would want our COVID unit or any other infectious disease unit, if we're utilizing cohorting, to look like. Next slide. So when I would describe, the COVID-19 outbreak in COVID-19 cohorting with facilities here in Montana, I'd often talk about 3 buckets. I would say, okay, we've got our first bucket, which is where we're going to keep our asymptomatic, negative, non-exposed residents, right? And that's going to be ideally 1 unit. Then we have what some individuals would call a warm unit or the yellow unit, or I heard, a lot of different things being used for this, but a quarantine area. And this is where asymptomatic, negative, exposed residents would be, right? We want them to be in a private room with their private bathroom. So once again, if they became cases, we're really limiting the exposure circle and the number of close contacts that we might have. And then the third bucket is isolation, where we would place positive residents. And this is where we cohort positives. They have to be positive unless we have a different MDRO. So for example, we wouldn't put, just because somebody had C. diff on the COVID-19 unit, right? We need to look at the pathogen. Cohorting is pathogen specific. And we also need to make sure that we confirm the diagnosis and that they're cases. So I always like to remind people quarantine equals exposed, isolation equals infection. So I equals I for isolation and infected. Next slide. Just some tips on what to avoid. We would want to avoid placing patients with pending testing on a dedicated infectious unit, right? If they have COVID-19 testing pending, we don't want to assume they're a case, put them on the COVID unit, it comes back negative, and now we've exposed them to COVID. We want to avoid keeping an exposed resident in the same room as a positive case. We don't want just to assume a roommate is exposed. We need to get them separated. We need to allow positive staff. We want to avoid allowing positive staff to work with negative residents. Once again, if we're in crisis mode, this might be something we have to do, but it's something we want to avoid if possible, just to limit potential exposures. We want to avoid staff working multiple units, once again, to just decrease the potential of exposing individuals that have not yet been exposed. When we are able to really dedicate staff, we're able to limit additional exposures throughout our facility. And then allowing residents in Jack and Jill bathrooms to share a bathroom if one's negative and the other one's either positive or on quarantine, once again, limiting exposures. And I know Jack and Jill bathrooms are a big thing here in Montana. We've got a lot of facilities that use them. And that's always something we try to discuss is what's the room situation look like and what's the bathroom situation look like? Next slide. And here are some cohorting considerations. So if we have to kind of look at who should be cohorted, does cohorting quarantine individuals make sense? Are we able to do it? We may need to do a little bit of a risk analysis, right? So how far into quarantine are the residents? Are they on day 6, 7 testing negative, asymptomatic? Or are we on day 1 or 2 after the exposure? Is symptom monitoring or testing occurring? Do we have the testing supplies to test as we should according to CDC guidance? Are the residents immunocompromised where they might be at a higher risk of becoming a case? Was the level of risk of exposure that put the resident in quarantine higher or lower? So was it an individual that their roommate was a positive case and they had really close contact, or was it, well, they may have passed in the hallway, we weren't quite sure, so we're just considering it a close contact? Can the resident wear a mask, perform hand hygiene, perform toileting, and practice physical distancing? It might be higher risk of a resident that can't wear a mask or can't perform hand hygiene, and they've had a high risk exposure, we want them on quarantine. What's the air exchange? How often are rooms cleaned and disinfected? And are there multiple organisms of concern? Are we dealing with multiple diseases during an outbreak? Next slide. And then just very quickly, I wanted to mention PPE use and cohorting. So I know when we talk about cohorting, we have a very specific unit set up. We also want to make sure that we're not using PPE from our units to units, right? So if I'm wearing PPE into the COVID-19 unit, I don't want to wear that same PPE onto a negative unit or even the quarantine unit. Or if I'm wearing something on individuals that are quarantined, I want to make sure I'm changing my PPE when I should, so I'm not exposing any additional individuals. Next slide. And that is all I have for you. So I know I went through it quickly, but I just wanted to do a very, very high level look at what cohorting is. Thank you, Jessie.
Thank you, Erica. That is a great summary on a very valuable topic. So I appreciate it. And I actually have a question for you too here. Let's see, have you seen or can you share what centers have done to meet staffing challenges while trying to maintain acceptable practices of cohorting? Any examples that stand out or anything that you've seen you can share with the group?
I think, oftentimes we look at it as a kind of a tiered response. And we also look at what exactly care or what activities are the staff doing, right? So maybe we can't do dedicated housekeeping, but then we say, okay, we're going to clean the non-affected unit first, and then at the end of the day, we're going to clean the COVID unit, right? So we're working from clean to dirty. So I think applying a lot of the general infection control tools and skills and education that we've already received, and then kind of applying it, always working in that clean to kind of dirty unit. I think sometimes I think a lot of facilities did this where if you had positive staff that were recovered, able to come back to work, then they worked the COVID unit, right? And then your negative staff that haven't had COVID worked the non-affected unit, things like that. I think sadly, a lot of our facilities have experienced staffing shortages, and it's something that we are very understanding of, and we do try to work with our facilities on. But like I said, we take it very seriously when we are going to allow a positive staff member to work with negative residents. We really want to make sure that all of our infection control measures are in place, and that the facility knows the expectations, and that we're not going to contribute to spread. So, but I would love to hear from other facilities and what they've done, if they've had any creative solutions to, I think, a nationwide issue.
Anyone on the line willing to share? Any additional questions? Yes, the recording and slides, they'll be finalized and we will send them out. Great. And you guys, there is a survey in the chat box. If you have a few moments, we'd sure appreciate you taking the time to complete it. Again, this was the 16th edition to our Worth a Shot series, and we appreciate everyone's time. We hope to see you next Wednesday, May 11th at same time, same place. Thank you, everyone.